This class is on allergic rhinitis. This class is mainly for undergraduate students. I will like to discuss the topic under the following headings: rhinitis, allergic rhinitis, classification of allergic rhinitis, pathogenesis, symptoms, signs, investigations, and treatment. So, rhinitis is defined clinically as having two or more symptoms, that is, either rhinorrhea or itching, nasal blockage, sneezing. So, among these four symptoms, if the patient is having at least two or more symptoms for 2 or more consecutive days and greater than 1 hour per day, that is the definition of rhinitis. So, rhinorrhea means nasal discharge, then itching of the nose, nasal blockage, sneezing. We can remember these four symptoms by the mnemonic RIBS, RIBS. So, R for rhinorrhea, I for itching, B for blockage of the nose, S for sneezing. So, what is allergic rhinitis? When the symptoms, that is, when these four symptoms are caused by allergen exposure leading to an IgE mediated reaction, then we call this as allergic rhinitis. It is classified as intermittent or persistent. So, when the symptoms are present only less than 4 days per week or less than 4 consecutive weeks per year, then it is intermittent. But if it is present more than 4 days per week or more than 4 consecutive weeks per year, then it is persistent. It is again divided as mild or moderate to severe. When the symptoms are doesn't cause any disturbance in sleep, that is, the patient is having normal sleep, normal daily activities, normal work, normal school activities, no troublesome symptoms, then we call it as mild. But when these symptoms are causing disturbance in the sleep, that is abnormal sleep, then impairment of the daily activities, it is causing some problems in school or work and troublesome symptoms, then we call it as moderate to severe allergic rhinitis. So, what is the pathogenesis? See, in normal individuals, these allergens like grass, pollens, or house dust mite do not elicit any symptoms. But in a patient who is predisposed to allergic rhinitis, these inhaled allergens, they are not completely cleared by the mucociliary system. So, what happens is that these allergens, they reach the antigen presenting cells. When the allergen reach the antigen presenting cells in the nose, which include the dendritic cells or the Langerhans cells. The antigen presenting cells, so this is the allergen, and we can see this allergen entering the allergen is taken up by the antigen presenting cells, that is the dendritic cells or the Langerhans cell. The antigen presenting cell will capture the antigen, process it, and present it to the T cells. The T cells in turn stimulate the B cells, and the B cells causes the B cells secrete antibodies, IgE antibodies, and these IgE antibodies gets attached to the mast cells. It gets attached to the we know that an antibody is having 2N, an Fc end, and an Fab end. So, the Ig antibody gets attached to the mast cells by Fc end. So, that is person in this stage we tell that the person is now sensitized to the allergen. That is, the allergen has already entered his body. The allergen is had it had caused the B lymphocytes secrete Ig antibody. The Ig antibody has already been bound to the mast cells by its Fc end. That is, the patient is already sensitized. Now, what happens is that when further exposure to the allergen, when there is further exposure to the or subsequent exposure, This allergen, they will get attached to the FAB end of this Ig antibody. This will cause the degranulation of the mast cells with the release of mediators, inflammatory mediators like histamine, leukotriene C4, prostaglandin D2, which leads to rhinorrhea, sneezing, then pruritus, nasal obstruction. So this is the mechanism of or the pathogenesis of allergic rhinitis. Then there is a delayed phase, that is when there is infiltration of the inflammatory due to infiltration of the inflammatory cells like eosinophils, neutrophils, basophils or monocytes at the site of antigen deposition. That may cause swelling or congestion. So that is the delayed phase. So that's all regarding the pathogenesis of allergic rhinitis. The sneezing and itching is mainly due to the nerve irritation. Rhinorrhea is due to loss of mucosal integrity, and vascular engorgement leads to nasal block. So the symptoms include, as I told earlier, either the patient will be having 2 or more of the symptoms of rhinorrhea, itching, nasal blockage or sneezing. Along with that, the patient may be having itchy eyes, pharyngeal itch, then atopic eczema, asthma, hyposmia, chronic cough, snoring, fatigue, sore throat, halitosis. These are not classical symptoms, but they may or may not be present. Signs: there may be signs of atopic diseases like eczema, allergic conjunctivitis. Then there are some classically described terms. One is allergic salute, that is repeated lifting of the nasal tip to relieve itching and open the nasal airway. This is called allergic salute. Then transverse nasal crease, we can appreciate that here in this diagram there is a transverse nasal crease called the Darier's crease or Hilton's line. Then Denny-Morgan creases, which is present in the lower eyelid, skin of the lower eyelid. This is the Denny-Morgan creases. Then allergic shyness, which is the dark discoloration below the lower eyelids, dark discoloration, called allergic shyness. These are some classically described terms, some signs of allergic rhinitis. Then the investigations. So that is or the management of allergic rhinitis. So whenever you are asked about the management, first tell the investigations, then tell about the treatment. So the simplest investigation, the specific investigations are 3: skin prick test, radio allergosorbent testing, and the nasal allergen challenge. These are the 3 specific investigations for allergic rhinitis, among which the skin prick test is the most commonly done. Here, as the diagram shows, here the different allergens are kept on a drop of these allergens are kept on the volar aspect of the forearm of the patient, and with a lancet a tiny prick is given so that the allergen enters the skin. Then we will wait for any reaction. Positive and negative control will be also kept. See in this diagram we can appreciate that, see when the grass allergen was injected, the patient developed a wheal, which suggests that that patient is sensitive to the grasp allergen. So that is a skin prick test, which is commonly done. The problem with skin prick test is that sometimes, rarely, there is a possibility of anaphylaxis while doing the skin prick test. So there's another investigation is the RAST, that is radio allergosorbent testing. That is, it's an in vitro test where we take the blood of the patient and measure the specific immunoglobulin E antibody concentration in the patient's serum. So when we compare the skin prick test and the RAST, the skin prick test gives an immediate result, while RAST, the result will take about days to weeks. RAST is very much expensive compared to skin prick test. The main advantage of the RAST is that it is very safe. That is, there is no chance of any anaphylaxis while doing the test. Also, it is not affected by treatment. The skin prick test may get affected after the treatment starts, but the RAST is not at all affected by the treatment. Then the gold standard investigation is the nasal allergen challenge test, where the patient is directly given the allergen so that the patient will inhale it, and we will observe the patient regarding any symptoms of allergy develops. But it is very rarely done. But it is the gold standard investigation for allergic rhinitis. So the treatment of allergic rhinitis, we can divide it into preventive therapy, pharmacotherapy, and immunotherapy. Preventive therapy means, as the name suggests, avoid the allergen as much as possible. But it's alone will not work. Along with the preventive therapy, we have to initiate other modalities of treatment, and that is the pharmacotherapy, that with the use of drugs. Many drugs has been described for allergic rhinitis. We can step by step we can look into each drug there, what is the action, and we know that there are four. The mainly we are treating the symptoms of the patient, that is the itching, then sneezing, nasal discharge, nasal block, impaired smell. So these drugs, some drugs are effective against some symptoms, some drugs are not effective against some symptoms. Certain drugs are effective against all symptoms. So we can look each one by one. So first is the sodium chromoglycate. See, sodium chromoglycate, it's a mast cell stabilizer. It prevents the degranulation of the mast cell. It is available as topical nasal spray. It is not much popular. The only indication is that in children less than 4 years, where there is no availability of topical corticosteroids. So in children less than 4 years, we can try sodium chromoglycate topical nasal spray, which is a mast cell stabilizer, which prevents the degranulation of the mast cell, and it may relieve the itching, sneezing, nasal discharge, and nasal blockage. Then comes the oral antihistamines, which is effective against nasal discharge, itching, and sneezing, but it has no effect or very minimal effect regarding the nasal blockage. You know about the oral antihistamines, like example cetirizine, levocetirizine, loratadine, desloratadine, etc. So that's about the oral antihistamines. Then come the ipratropium bromate, which is an anticholinergic drug, which is very effective in relieving watery rhinorrhea. See, but it has no effect against other symptoms like itching, nasal blockage, impaired smell. It has no effect. It is only effective against watery rhinorrhea. It's an anticholinergic drug. Then comes the topical decongestants like the cyclomethazoline, oxymetazoline, etc., which are alpha adrenergic agonists, which constricts the blood vessels and reduce the nasal congestion and edema. But the problem is that it is recommended only for a short term use, because it causes rebound congestion. and that terminology is called rhinitis medicamentosa. So the topical decongestion should be used only for a short time. So what's the is effective against nasal blockage. See, it is effective against nasal blockage, but it has not much effect on itching, discharge, impaired smell. Then comes the topical steroids, that is beclomethasone, budesonide, fluticasone, mometasone, etc., which reduce the inflammation. It has low bioavailability, so the systemic absorption is minimal. It's safe, and it is see that it's almost effective against all the symptoms, that is itching. It relieves the itching, it relieves the discharge, it relieves the blockage. Even in impaired smell also it has some effect. The advantage is that the topical corticosteroids has minimal bioavailability, so the systemic absorption is minimal, so it's safe. It can also be used for long term, that is for 2 to 3 months we can use it in contrast to the topical decongestants, which can be used only for a short time. The topical steroids can be used for 2 to 3 months. Then comes to the systemic steroids, the oral corticosteroids, which is the most effective drug. It is the most effective drug in allergic rhinitis. It is effective against all the symptoms. Actually in patients with impaired smell, it is the only drug which is effective. That is oral corticosteroids. It relieves itching, relieves discharge, relieves blockage, and relieves hyposmia. But the problem is that it has systemic side effects, so we cannot use it indefinitely. We can be used only for intermittent use. We cannot use that drug for long term. Then comes the anti-leukotrienes, that is the montelukast, sulfilukast, etc. It's also effective against nasal discharge, blockage, etc. Usually it is combined with the oral antihistamines. So these are the drugs for allergic rhinitis. Now there is a step-by-step approach for the treatment of allergic rhinitis. See, the step-by-step approach is that the first modality is avoid the allergen. That is the first treatment, that is preventive therapy. After preventive therapy, the patient is having symptom, then start with intranasal decongestants for less than 10 days. Example, cyclomethaxolone or oxymetazoline nasal drops, along with a oral antihistamines. So an oral antihistamine combined with a topical nasal decongestant for less than 10 days. We will start with that for mild or intermittent symptoms. But if it is not responding, then we have to go for intranasal steroids. In children, since intranasal steroid is not available for children less than 4 years, we may have to start sodium chromoglycate. Even with that intranasal steroid, the patient is not getting benefit, then we may have to go for systemic oral steroids. Even with oral steroids, the patient is not getting any benefit. The final modality of treatment is immunotherapy. So what is immunotherapy? Immunotherapy means repeated administration of an allergen extract in order to induce a state of immunological tolerance. That is, we are repeatedly administering the suspected allergen to the patient. This can be administered either through the subcutaneous route or sublingual route. The first route is called SCIT, subcutaneous immunotherapy. The second route, that is the sublingual route, is called SLIT, sublingual immunotherapy. So what is the mechanism of action? We are repeatedly administering the allergen extract in order to induce a state of immunological tolerance. and this causes reduction in clinical symptoms and the requirement for medication during subsequent natural allergen exposure. So that is the principle of immunotherapy, which is the last resort. So that is a step-by-step approach in the management of allergic rhinitis. Thank you.